A quick review: the pharmacology of the local anesthetic agents. The clinical effects for the local anesthetic agents will be terminated by reabsorption through the general circulation whenever it will be absorbed or will be taken through the blood. We have the ester type. It will be going to metabolize by pseudocholinesterase, or what we call it butyrylcholinesterase, or the other name plasma cholinesterase. And whenever it will be metabolized by this enzyme, the ester type is going to produce para-aminobenzoic acid. The para-aminobenzoic acid, this chemical substance, is the one responsible about the toxicity or the side effect, the allergic side effects that will be produced by the ester type of local anesthetic agent. The other types of local anesthetic agents, the amide group, it will be taken through the blood until it will be reaching to the liver, and then it will be metabolized in the liver. So that's the way how the ester type or the amide type, it will be, their action will be terminated by whenever they are away from the nerve terminal. And now for some of the toxicity or side effects of this local anesthetic agent. The ester type will produce angioedema. As you can see, it is a serious toxicity and the serious side effects. And also they will be increasing the incidence of the allergic reaction urticaria. Methemoglobinemia, it is really a serious side effect that it might be produced by benzocaine or lidocaine or brilocaine. And probably that's the reason we have seen that the benzocaine should not be used in children to treat the teething problems. And the methemoglobinemia will produce a continuous discoloration, a gray color, as you can see it here. And the methemoglobinemia, it should be initially treated symptomatically. Then a subsequent treatment will be guided by the blood levels of methemoglobin. And here, most probably, we need to give methylene blue IV and also vitamin C IV. And in some cases, the utilization of hyperbaric oxygen may be required, specifically if we have a severe cases. And now for the toxicity or the side effects that will be present in the different types of local anesthetic agent. We have circumoral or a tongue numbness. We have the metallic taste, the dizziness, difficulty focusing, noise in the ears, disorientation or confusion, and the drowsiness. And if we reach to a very high level of toxicity, we have muscle twitching. It may be reached to a convulsive activity because the local anesthetic agent is going to depress the inhibitory system in the brain. So that will be leading to a convulsive activity. And then it's going to block everything in the brain, the inhibitory system and the stimulatory system. So that will be leading to a coma. And will be reaching to a respiratory arrest and finally to cardiac arrest. So we have seen that the most serious systemic toxicity that will be produced by local anesthetic agent, it is the one that will be affecting the central nervous system and will be leading to a serious convulsive activity. Also the ones that will be affecting the heart and will be leading to a cardiac arrest. So now for the treatment or the management of local anesthetic systemic toxicity. So first of all, we need to stop immediately the injection of the local anesthetic agent, and we need to make an immediate take care of the ventilation and oxygenation. Now, if the patient have a seizures activity, then the best medication is the benzodiazepines. Midazolam, for an example, or lorazepam. This is the best medication to stop the convulsive activity. It may be given the propofol, but it's supposed to be with a very low dose because there is a risk of potentiating the cardiovascular toxicity. Also, it may be used the barbituriate, like phenobarbital for an example, or thiopental, and even sometimes if it is not stopped by the previous medication, we might be using a succinylcholine, the neuromuscular blocking agent. Now, if the patient reached to the level of a cardiac arrest or ventricular arrhythmia, then here we give a very low dose of epinephrine or adrenaline, less than 1 microgram per kilogram, just like to see how it will be responding. And you should be avoiding the vasopressin because it will be leading to pulmonary hemorrhage. And definitely in this type of dysrhythmia, you are supposed not to use the calcium channel blocker or the beta receptor blocker. They are not recommended. And if you have a ventricular arrhythmia, so then you are going to use, the best is to use the amiodarone and not to use the lidocaine, for an example, as a local anesthetic. We know that, or brocainamide. Don't use it because they are going to increase the toxicity upon the heart. And finally, you are going to introduce, if this medication is not so useful, you go and use the lipid emulsion, intralipid, at a concentration of 20%. So we give 1.5 ml per kilogram within a minute, and then we make a continuous drip of 0.25 up to 0.5 ml per kilogram per minute. We continue the infusion for about 30 to 60 minutes, and we might be repeating the dose. However, the infusion should be continued for about like 10 minutes after the hemodynamic stability is there. And I am going to explain in a little bit how this lipid emulsion will be producing their effect against the cardiotoxicity. And finally, if the patient is not responding, we might be going to the cardiopulmonary bypass, and we shall continue this until we clear all the local anesthetic agent. So after the infusion of the intralipid 20%. The lipid emulsion will be present in the blood as emulsified oil droplets. Now, that's we know in the body now. The major toxicity, we said it is in the brain and in the heart. So we have in the brain and in the heart, we have higher concentration of local anesthetic agent, which it is lipid soluble. So it's going now to be moving from the brain and the heart to this oil droplet. And then these droplets, which containing now the local anesthetic agent, they are going to deliver it to the low concentration organs like the liver to be metabolized there or to be stored in the skeletal muscles. So we have a shuttle here from the higher concentration to the lower concentration. By this way, we are decreasing the toxicity of the local anesthetic agent upon the central nervous system and the heart. We said after the infusion of the intralipid, the lipid emulsion will be present in the blood as emulsified oil droplets. And that will be attracting the local anesthetic agent from the high concentration in the tissue to the blood, and then it will be entering this droplet. And that's what we call it lipid sink. So here we have then the local anesthetic agent inside this lipid droplet and will be delivering to the liver, for an example, to be metabolized. Another mechanism that this droplet will be delivering free fatty acid. The free fatty acid now will be going through the cell membrane to be inside. Whenever it is inside, it's going to interact with carnitine and to produce a fatty acyl carnitine. And the fatty acyl carnitine is going to activate or keep the mitochondria working. So we have an increase in fatty acid uptake by the mitochondria, what we call it metabolic effect, and that will be leading to keeping the mitochondria able to generate adenosine triphosphate. Also, another mechanism that we have the free fatty acid, which it is now inside the cells. It will be activating a specific enzyme. We call it this enzyme, it is a serine threonine protein kinase. It is very important for the cell survival, for the cell proliferation and migration. And it's also called a protein kinase B. Now, the activation of this protein kinase B is going to produce an inhibition for a specific another enzyme. We call it glycogen synthase kinase 3 beta, which will be this enzyme. If you inhibiting that, will prevent the myocardial ischemia, reperfusion injury. So it is very effective as a cytoprotection. Then whenever you inhibit this enzyme, you are producing some kind of a cytoprotection effect. Also, the free fatty acid will be accelerating, probably will promote the calcium entry through a specific voltage dependent calcium channel, and that will be again keeping the, for an example, the heart to be able to generate an action potential and also to generate what we call it excitation contraction coupling. So we have now an ability of the heart to produce a contraction. Now, beside all of that, also we have the free fatty acid will interfere with the local anesthetic binding to the sodium channel. So that's what we call it here, a membrane effect. And finally, we have also an accelerated shunting from, as we said in the beginning, that the local anesthetic agent now in the droplets will be going to the liver to be metabolized or going to the skeletal muscle to be stored. And that's what we call it also a pharmacokinetic effect. So by all of these mechanisms, we understand somehow to explain why this intralipid is effective in the management of local anesthetic systemic toxicity.